Thank you for joining us today. The Community Rounds workshop series is a live webinar series provided monthly by the University of Vermont Center on Rural Addiction to provide opportunities for health professionals to learn and ask questions. And we discuss topics related to science-based best practices for substance use disorders. Sessions usually include about 45 minutes of presentation, followed by 15 minutes or so for questions and conversation. Before we begin today's session, I'd like to go over just a couple of reminders. We do encourage you to ask questions, but we ask that you please save them for the time reserved at the end, or you can feel free to enter them into the Q&A box during the session, and we'll make sure to answer them at the end during the Q&A period. But if we run out of time for all of them, we will follow up with you via email. The presentation is being recorded, and a recording of the session and the slides will be shared following the presentation. You can expect to receive them via email next Friday, July 9th. So we are about to launch a poll here, which is to assess people's familiarity with motivational interviewing. And we'd love to have you fill it out as you're getting settled in. At the end of the session, another poll will be shared in the last couple minutes to assist us with evaluation. And we'd love to have you stay to complete that poll as well. So if people are comfortable, please use the chat box to introduce yourself to the group by sharing your name and your organization and what community you're coming from. And when you do that, just make sure you select panelists and attendees so everybody can see who's here. Continuing education credits are available for those who attend this session live, and we'll share the link in the chat box during the session for instructions on how to claim your credits. You'll also get them via email when you receive the recording and slides next week. And if you have any questions, you can contact us at cora@uvm.edu. We do ask that you claim these credits within 30 days of the live webinar. There are no disclosures for this community round session, and all potential conflicts of interest have been resolved. So at this point, I'd like to welcome Dr. Robert Althoff, who is Associate Professor of Psychiatry, Pediatrics, and Psychological Sciences at the UVM Larner College of Medicine. He is here today to introduce our speaker, Dr. Peter Jackson. Thank you, Dr. Althoff. I will turn it over to you.
Sure, thank you. And it's great to be here to introduce my friend and colleague, Dr. Peter Jackson. Dr. Jackson is an assistant professor at the University of Vermont Larner College of Medicine and the UVM Medical Center. And he specializes in both child and adolescent psychiatry and addiction psychiatry. In both the American Academy of Child and Adolescent Psychiatry and the American Academy of Addiction Psychiatry, he currently serves on committees responsible for preventing and treating substance use disorders in teens and treating families. He completed medical school at the University of Utah School of Medicine, residency at the University of Michigan Medical Center, and completed fellowships in both child and adolescent psychiatry and addiction psychiatry at Harvard Medical School. His writing and teaching have included additional emphasis on the role of parents and family members in the prevention and treatment of substance use disorders. We were lucky enough to recruit Dr. Jackson to join us here at the University of Vermont, and looking forward to hearing him share his expertise today on motivational interviewing. So welcome, Peter, and thank you for sharing your time with us today.
Thanks so much, Rob. I'm excited to be here today, and I'm particularly excited to talk about this topic because it was hugely influential for me in sort of career path choices. And so very excited about it. I hope today that we'll be able to increase our compassion. I think that's like my favorite session objective that I hope is always part of our goals. But really to understand the spirit and some of the guiding principles of motivational interviewing. There are lots of skills and tools that can be practiced with motivational interviewing. Today, my hope is really to help us believe that they're worth incorporating into our practice and be ready to practice them. We'll do more sort of practicing in subsequent sessions. This approach helps us value patient autonomy and helps us foster collaboration in our treatment, helping us meet our patients where they're at. And I think particularly now, it's been a difficult year. We'll talk about that a little bit, but motivational interviewing being incorporated into our practice can actually really help decrease burnout and decrease compassion fatigue. And we'll talk about that a little bit. So, and then in the end, yeah, hopefully prepare us to be ready to practice at future sessions and learn more about sort of incorporating specific skills into our treatment. So as I mentioned, this has been a difficult year. I think it's been a difficult year no matter what your setting is. But I know particularly in rural areas, this has been challenging. Across the country right now, there's lots of studies going on about provider burnout, the difficulties that we're facing. So here's a table from one of the studies looking at this that talks about, are there differences in burnout between urban areas and rural areas? So the top cause there, challenging clients, that in of itself has some has a little bit of innuendo to it, but challenging clients, a large caseload, the burden of paperwork, and then particularly in rural areas was found to include office politics and low prestige in the field of treating substance use disorders and mental health challenges. One interestingly to me that was specific to urban areas was a frequency of changing jobs. I think the opposite could be true in rural areas. The idea that you can't walk across the street to the next health system and get a new job there. But thinking about this, I think it's important for us to just mention it. I know that within our health system, sort of the volume of need is at a maximum right now. And I think that's happening in all areas, inpatient treatment, outpatient treatment, and everything in between. So the reason why I felt like it's really important to mention this is because of my hope that as we incorporate motivational interviewing and thinking in that way into treatment, that we will be able to decrease the likelihood of burnout or decrease the impacts of burnout. So I wanted to take just even 20 or 30 seconds to pause and ask everybody to think about these questions. What are some of the biggest challenges that are facing us in our work? What gets in your way? What types of things worry you the most in providing treatment for individuals impacted by substance use disorders? And then a couple of questions. What in the past has helped you be successful in treatment of substance use disorders? And then these last two questions kind of flipping. What are the things that make you motivated and excited and feel energy for the work that we do? And what are some of the things that might make you want to run away or might make you need a break, those types of things. So I'm going to pause for just 10 more seconds, and I want everybody to think about that for themselves for a moment. One thing that I really have experienced in my own care, in my own professional work, is that motivational interviewing is excellent to incorporate in our treatment that will help us provide better care to help patients. So it will improve patient care, but it will also improve provider experience. I think the extremes of this slide are two areas that are a recipe for disaster with burnout. One is sort of that fatigue, maybe that jaded feeling like I can't do anything about this. These problems are unsolvable. More subtle, I think, is this idea that we actually can solve it all and we can take care of it all. And so solving this with balance, motivational interviewing will help us do this. Help us avoid the idea like I can't do anything about this. It also helps us avoid the idea like it's our responsibility to sort of foster all of the change. So let me start out with a couple of stories that have to do with speaking. We're going to talk today about why how we speak with people matters. And I wanted to just share a couple of experiences and analogy to think about. So many years ago, I took basically a serious crash course in Italian and getting ready to go and live in Italy for a couple of years. It was 9 weeks of basically learning Italian almost all day, every day, just diving in and learning and learning and learning and learning, and included, memorizing and just like getting as much of that language under my belt as I possibly could. After the 9 weeks, I arrived, bright-eyed and ready to go. So excited to speak to the people living in Italy, and so excited to find somebody and sort of show them my amazing Italian. So I will never forget the first person I went and talked to. I was like all set. I was like ready. I had learned all my Italian. I had, part of this communication like memorized, and I'm all excited. So I'm talking to somebody just on the sidewalk and learning and talking, and I just deliver what I thought was perfection. Like I've got the accent down. I've got the language down. I'm so excited. And after I spoke in a terrible way, didn't ask questions, didn't do any listening. And I delivered this thing that I thought like, oh, that's going to be so awesome. It's so cool. I speak Italian. And this individual turned to my friend and all they said was, "Non ho capito," which is, I didn't understand any of that. I don't get it. I didn't hear it. I have not understood. Direct translation. So we often think that we are speaking someone else's language, but we're actually not. I think this can particularly apply in treatment in rural areas. The US is a big place, and cultural norms and dialect, so to speak, the way that we approach treatment, it varies from place to place. And so the ability to speak to somebody in a way that is their language and not our own is really important, including in rural areas. So I came home from Italy. So, by that point, 2 years later, I think I actually was speaking Italian pretty well. And I got a job teaching Italian at my undergraduate institution. So I was really excited. I was going to teach Italian 101 and learn these, learn leadership skills, learn teaching skills. I was going to get to be in charge. I created the lesson plans, et cetera. And I'm so excited for this job. The woman who had hired me was incredibly competent and kind, but has high expectations. I was actually pretty intimidated. And I remember I went in, so I'm hired for the job. I'm all excited. And I go in to sort of learn what my responsibilities are going to be. And she tells me, "Okay, this is exciting. We're glad to have you. Good luck teaching. I have 2 rules for you. Rule number 1, you cannot speak English. And rule number 2, you can only speak for 20% of the class time." So I have this job, and then I felt like I'm saddled with these impossible rules. 2 rules: I'm not allowed to speak English, and I can only speak for 20% of the class time. So I am teaching Italian 101. Like nobody knows Italian. So how are we going to do this? So I arrogantly think this is not possible. There's no way to do this. And I'm going to approach this kind of in my own way. So I definitely was speaking some English during these introductions and telling my class. And I certainly don't think I was doing the 80-20 rule. So I walk into class about, maybe it's like my 3rd day of teaching, the end of the first week. And there in the corner is Ilona Klein, this woman who hired me. And she's sitting in the back, just looks at me and holds up a stopwatch. And I didn't have any time. She walked in, I think intentionally, like 40 seconds before the class was supposed to start, and she was there holding a stopwatch. So long story short, she came up to me afterwards and she said, "I told you the rules, and you just spoke for 62% of that class time. And so she kind of, she scolded me a little bit and told me I needed to change my teaching approach. I did change my teaching approach, and I started going into class. I basically had to mime everything, but I stopped speaking English and I started not speaking very much, and then just forcing the students to open up their books and sort of sloppily move our way through it. But the moral of this story is, how was I expecting the students to learn Italian while I was speaking English? They're supposed to speak Italian, but instead I was speaking English. And so this is an application to motivational interviewing. How would our patients learn about their reasons for change if we're talking about our reasons they should change? So I want you to sort of hold on to that, because to me, that was a really practical implication and a way that I sort of learned that in my life. So let's talk a little bit about it. So motivational, sometimes I think it's a little bit of a misnomer. I think we think of motivational interviewing like it's going to be motivational. It's going to be super inspiring, life-changing, totally convincing, like a TED Talk or a really good sales pitch. I don't know, has anybody seen the old Saturday Night Live skit with Chris Farley when he's Matt Foley, the motivational speaker? This is a hilarious skit. So I see a couple of people have raised their hand. I hope that's people who have seen the skit. You can look it up. It's very funny. Chris Farley was classic. Sadly, Chris Farley passed away from substance overdose. But what Chris Farley does in this video is not motivational interviewing. So it's not a motivational speaker. But if you want to go look at this, it's very funny. It's also not a browbeating. It's not a sort of doing an intervention. So it's not this sort of amazing, inspiring speech, and it's also not a scare tactic or anything like that. Motivational interviewing, I'm going to use lots of quotes from the most recent edition of Motivational Interviewing by Miller and Rolnick. The book that can potentially be available to you guys at the end that Nellie will talk about is sort of a basically a shortened version of that for healthcare. But I like this quote: motivational interviewing is a method of communication rather than a set of techniques. There are skills involved and there are things to sort of practice, but it is a method of communication. It's not a bag of tricks for getting people to do what they don't want to do. It's a fundamental way of being with and for people. I really like that. It's a way of being with and for people. I also like this other quote. It's about arranging conversations so that people can talk themselves into change based on their values and their interests. And often in the book and in other places, you'll see motivational interviewing compared to a dance rather than a wrestle. So I think that's important. So I want to launch in and think about this. So it's a mindset. If you have the opportunity to get one of these books, the motivational interviewing books, they'll start out with sort of the spirit of motivational interviewing. In the full version of the book, that's chapter 2. And it's like worth reading and then rereading and then rereading again, because no matter how practiced I think we are in certain techniques or skills, if we don't do it in this spirit, it's not gonna go well. So you're also gonna see in motivational interviewing, there are all sorts of like acronyms and triads and quartets and sort of things. So this is the first quartet that I'm going to mention to you, is the spirit of motivational interviewing, which includes partnership, evocation, which is really people already have within themselves what is needed for change. We're trying to help them bring it out. We're focusing on their strengths and trying to understand their strengths rather than probing for deficits, and sort of recognizing that people who are ambivalent already have both arguments in them. So ambivalence is normal, and people already have an argument to change and an argument to not change within them. And so we're trying to pull out and understand what that is. So partnership, evocation, compassion, and acceptance. And we'll talk about these a little bit more. So compassion, I've always liked kind of the distinction of empathy and sympathy. One feels sort of top down to me, sort of like, oh, sympathy, I feel for you. Whereas empathy, I think, is a higher level of compassion that allows us to feel with somebody and come alongside them. So that's one of the four sort of pillars of the spirit of MI is compassion. I mentioned this in a previous webinar, but I think this idea of unconditional positive regard is really valuable. Again, Carl Rogers sort of came up with this person-centered approach, and I'm going to quote him again. He sort of says the idea of this is that an individual has within him or herself vast resources for self-understanding, for altering their self-concept, attitudes, and self-directed behavior. And that those resources can be tapped if we can create a climate for facilitating change. So I think that's really important. So compassion, leading in with compassion. Next is acceptance. And acceptance is broken down into the 4 A's. So again, like I told you, motivational interviewing, it's going to be perfect if you want to put sticky notes somewhere on your wall. You can do the four A's, the four pillars. We'll talk about lots of these, but acceptance is broken down into absolute worth. I love this idea that we don't have to decide who deserves and who does not deserve respect. This belief that this other person sitting with us is a fundamentally trustworthy and worthy person. That helps us achieve accurate empathy, which they describe as the ability to understand another person's frame of reference and the conviction that it's worthwhile to do so. I think that second part is really beautiful. So the ability to understand someone else's frame of reference and our conviction that that's the right thing to do. Supporting autonomy, which is our ability to let go of the idea that we have to or that we even can make somebody change. Like I talked about earlier, that recipe for burnout, sort of the I can't do anything about this or I can fix this sort of independently, both of those are really exhausting if we take those approaches. And then affirmation. We're looking to acknowledge, seek out and acknowledge and reinforce someone's strengths and their efforts. So that's the acceptance. So we talked about compassion and acceptance. Next is collaboration. Motivational interviewing is not done to somebody or on somebody. It's done for someone and with somebody. I like that distinction in the book. And this idea that people are the undisputed experts on themselves. They are the undisputed experts on themselves. No one has been with them longer or knows them better than they do themselves. They have vital expertise that can complement our own expertise. We become a witness to change, and as we take a collaborative approach, we might start, instead of just giving instructions, we might ask permission as we're participating in this, in sort of a tag team effort. So we think about that. We think about two experts that are working together. This is how we support autonomy. You're the expert in you. I have clinical expertise in some of the treatment modalities and how to work in this field, and how do we work together and combine those areas of expertise. This is just another reference that instead of giving someone what they lack, we're trying to bring out what they already have. One thing that I think can be particularly applicable to rural communities is that we can often see a higher emphasis on autonomy at times in rural communities. People that are used to taking care of more of their own things, there's not as big of a community, and there's not sort of ready resources kind of across the street or down the street all the time. And so there are some studies that have shown, and I mentioned this in our stigma webinar, that have shown that people in rural communities can often have an even higher value a higher value on autonomy compared to those in urban settings. So this is an incredibly important part of motivational interviewing. So that's the spirit of motivational interviewing. The next sort of quartet that we're going to talk about is this rule, RULE. And these are described as the guiding principles of motivational interviewing. Again, my feeling, my strong feeling is that prior to going in and just starting to try to learn skills, tools, strategies, is gaining the spirit and some of these core principles of motivational interviewing. So that's where we're spending most of our time and energy today. So RULE, it's an acronym: resist the writing reflex, understand their motivation, listen, and empower the patient. I want to mention briefly the writing reflex. This is so natural for us to do, especially for those of us that have chosen helping professions. We want to be helping people. We want to sort of prevent harm for people. We want to prevent hurt for people. And so our natural inclination is to sort of say, stop. That's the wrong way you're going. There's a better way. Stop and come go this direction. When someone is ambivalent, again, they already have both arguments within them. And when we push only one of those directions, a natural tendency can be for somebody to then do the counter argument. So we have these two, what seem to me to be universal human tendencies. One is we don't really like being told what to do. And number two is we like our own ideas more than other people's ideas. And so I think that's a pretty natural thing to have happen. It can bother us, or we can be like annoyed by that as clinicians, but I think that happens for all of us. We don't like being told what to do very much, and we like it when it's our idea more than when it's somebody else's idea. Particularly applicable to teenagers. So I like this other quote from the book, is that someone will learn about their attitudes and beliefs the same way that we would learn about their attitudes and beliefs, which is basically by hearing them talk. They need to hear themselves talk. So this goes to that Italian sort of rule. How was this class supposed to learn Italian while I'm speaking English? How is somebody supposed to learn about their motivations and beliefs if I'm telling them about my motivations and beliefs for them? Ask yourself, if you're driving, which of these two approaches do you tend to respond to more? There have been studies that have shown that when people are just presented with information in a non-accusatory way, that they will actually change their behavior more than if they're sort of told in a critical way. So I don't know how you guys feel, but I think a lot of people experience this sign on the left, like, that's just information. Here's the speed limit. Here's how fast you're going. Versus this big flashing, like shaming, slow down, you're going too fast. This is an analogy of the motivational interviewing approach. So when we think about the guiding principles, resisting the writing reflex, which we just talked about, understanding someone's motivation, listening to them and empowering them, we can really lay these on top of the stages of change model that comes from Prochaska and DiClemente. One of the areas of burnout is sort of like, we're going to change this, right? And I think sometimes we find ourselves in treatment hoping that in a first conversation or in just a small amount of time, we're going to help somebody move through every step of these stages of change. It can happen. It can happen that people move quickly. But I like the idea that in a motivational interviewing approach, any step forward in this process is valuable. So I remember that being pretty important to me when I was in my training, that if, the goal of in one interview, getting somebody from sort of pre-contemplation to action is sometimes unrealistic or unlikely. But if that's what we think, like that someone's not ready and we have to get them ready and moving, I think that can be a recipe for us to burn out. So thinking about applying these principles and moving people sort of one step along the way, breaking these down. So if somebody's in that first stage of pre-contemplation, we're basically just trying to raise awareness. In contemplation, we're trying to help them resolve ambivalence and helping them sort of find their own motivations to change. Preparation or determination is helping them identify the resources to help and support change. And then these other steps. So a lot of motivational interviewing, the approach, the spirit of it can help us as we're interviewing and working with people at every stage in this process. One thing that we think about a lot is sort of the communication styles that come along with motivational interviewing. So thinking about breaking it down into these three styles, a directing style, a guiding style, and a following style. Motivational interviewing is really in the center lane there, a guiding style. And I like all of these additional sort of descriptors of what that looks like. So I particularly like the difference between steering and pointing and telling and showing that I think are pretty powerful. And so thinking about these as we go through, our work can be really powerful. The directing is, that errs on the side of sort of authoritative, and following errs on the side at times of not giving enough of our expertise or not sort of helping. But sometimes the following style is fine when we're beginning our conversations and we're building sort of a therapeutic alliance with somebody. Another thing that might be particularly applicable to rural areas is if we're using telehealth. Absolutely, MI is great via telehealth. It can be done just as well through telehealth as any other sort of therapeutic intervention. But some studies have shown that with telehealth, you need more time for building rapport and developing a therapeutic alliance. So the following style might actually be utilized more or for a longer period of time if we're working with somebody through telehealth as we're building that therapeutic alliance. But again, we're changing our mindset from confronting somebody or I'm going to educate you and tell you what to do, and I've got the right answers. We're changing that to I want to collaborate and work together. I'm going to try to help pull out from you or understand better from you your own reasons to change and respect your autonomy while we do that. Here is the next sort of quartet that you'll see in motivational interviewing is what's called the 4 pillars. And they overlap a little bit with the spirit of MI. Expressing empathy, and we talked a lot about empathy in the beginning, developing discrepancy, supporting self-efficacy, and then rolling with resistance. So expressing empathy, accurate empathy, as they described before. I put this quote in there again because I love the 2 parts of it: the ability to understand another person's frame of reference and our just belief that that's the right thing to do. So listening actively and reflecting back. Developing discrepancy, this is sort of expanding maybe on somebody's ambivalence. And these types of conversations, sort of the discrepancy meaning the difference between where somebody's at right now and where they want to be. This, if done with respect for autonomy and compassion, can be really powerful. Where do you want to be? What's most important to you? And finding what are their key values and their key beliefs, and how does their substance use fit into that? That helps to develop the discrepancy. That's helping them create their own reasons to make change. So expressing empathy, develop discrepancy. The next pillar is supporting self-efficacy. Again, recognizing that only they can carry out the change. We can support them. We often will express our belief that they have the capability to make the change, but sort of alleviating ourselves of the idea that we have to make the change. And then rolling with resistance. This is something that we won't go into in detail. I think it's a little bit more of a sort of specific skill-based area, but avoiding arguing, often not directly opposing resistance, recognizing that resistance and ambivalence is a very normal part of the process. Their perspective is always welcomed. If we feel a lot of resistance, we can think of that not as a stubborn person, but maybe that's a signal for me that I might need to respond a bit differently. I might need to change sort of the way that I'm approaching this. And then often sort of turning some of the questions back to the patient for solutions. That's a good question. Why would you make that change? Why would you do something different? But if we find ourselves getting into an argument, we've definitely lost therapeutic traction there. So there are some specific skills and approaches that I've included in the slides. So I'm going to send these out, but this is where a subsequent webinar for us and, basically practice sessions that we're hoping to put together in the future are going to be helpful. But here's a list of some of the sort of the beginning skills to learn about. OARS is a common acronym used in motivational interviewing. Open-ended questions, affirmations, reflections, and summaries. This is where we, in the future, will divide up into groups and practice practice asking these questions. So open questions, it's very straightforward. It's not a yes or no question. It asks them to think more about sort of what's been going on for them. Here's an example of some of the open-ended questions. So that's O for ORs. Affirmations, we're constantly looking out for their strengths. We're constantly looking out for the good steps that they're taking, for their good intentions. And this is exactly the opposite of that idea, that caveman cartoon where that someone will change if we make them feel bad enough. Reflections is basically just mirroring back as we're having this conversation. This is reflective listening. It's pretty basic therapeutic technique, but it can just be stating back. So what I hear you saying is this, or we can try amplifying a little bit, or we can reflect back. It sounds like you're feeling two ways. You're feeling both this and this. And then summaries. So this is the end of ORs, open-ended questions, affirmations, reflections, and summaries. Think about all the things that you've heard them talk about for change, and then handing that back to them at the end of the conversation. When they say, I wish I could, or I should, or I want to, or I might be able to, sort of handing them back those things in a summary. This is what's in motivational interviewing called change talk. When you hear somebody talk about change, they may be sort of giving both sides and sharing their ambivalence. We are providing them with an opportunity to expand more on the change talk. Can you tell me a little bit more about that? Can you give me an example? And that's done in our affirmations and in our reflections. Probably another tool you've probably heard of is the change ruler. We're sort of assessing the importance of change, confidence for change, and sometimes readiness to change on a scale of 0 to 10. And then you can query the extremes. So on a scale of 0 to 10, how important is it to you to decrease your alcohol use? If they say 3, then you can say, why is it not lower than a 3? And explore everything that sort of brings them towards motivation. And why do you think it's not higher than a 3? That's just an opportunity to look really broadly using that change ruler. Probably something that people are familiar with, but takes a lot of practice. Exploring the decisional balance, pros and cons. This is another thing that's used commonly. What are the best things about this period of recovery that you've had, or this period of abstaining from substances? What's been the hardest part about that? And the same thing, giving equal time to their ambivalence, not ignoring that they have both arguments within them. What are some of the things that have drawn you towards that substance the very most? I had a experience with this just yesterday, talking with a gentleman who's been using substances and sort of finding out this severe anxiety and depression that he's been experiencing, by saying, what's the best thing, is his sort of referencing that I don't have to experience that. Became very emotional and was very sincere in explaining what the draw is, and helped me a lot to understand his reasons to change some things, but his opposition or ambivalence about changing other things. So decisional balance exercise. Normalization, I think, can be a powerful part of our motivational interviewing. Most people I meet say good and bad things about this. Most people have mixed feelings about these issues. And then when we give feedback to people, it's sort of the ask, tell, ask. This respects autonomy. Can I share some of my thoughts with you? Sure, go ahead. Here's what I've observed. Here's some of the things that I'm thinking. Here's a little bit of, I'm contributing my expertise to the conversation. What are your thoughts about what I've shared? Ask, tell, ask when we give feedback. So those are briefly just some of the skills, and I'm sorry to go through them quickly, but I want to introduce some of them and have them in the slides. And this is where really it's practice, practice, practice. Motivational interviewing is like learning a language or like learning an instrument. Practice, 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 practice. It's not like learning to ride a bike, where it's sort of like in this moment, click, something happened in my cerebellum. I now know how to balance on a bicycle, and you don't really forget how to ride a bike. But this is more like practice, practice, practice. We mentioned this a little bit, but here's some of the areas where I think that motivational interviewing can help us feel less burned out. If we think that it's either ready or not ready, that can be really discouraging. But with motivational interviewing, we can think about somebody taking any small step along that path and moving forward. If we think about only abstinence-based or harm reduction, that can leave us feeling stuck and feeling like it's our decision what path this person's going to take forward. We definitely get to provide our recommendations, our clinical expertise, but motivational interviewing helps us think more broadly about there are multiple paths that people have towards improvement, and we can be a companion with them as they seek out and find reasons for them to make change. Again, I think motivational interviewing, one of the most powerful things that it does for us is it helps us increase our compassion, our patience, and it just when I can do this in clinical care, I just feel so much less burdened. I feel so much less burdened. I feel way more engaged. So I myself need to revisit these principles frequently, sort of look them back up again, read chapter 2 of the book, The Spirit of MI, frequently. And it helps me feel so much more energized for the work and so much less burdened by false ideas that I can either be totally in control or it's too hard and I can't make this person change. Thinking about how this applies in rural settings particularly, when somebody feels judged or somebody feels accused or they don't feel like there's a partnership in the treatment, that spreads pretty quickly. And particularly in a rural area, that can spread more quickly and can distribute more completely. And there might not be other options for people to receive treatment. So this is a way to increase compassionate care. It's a way to help people feel empowered coming into treatment. And we talked about this, that sometimes this culture of self-efficacy or self-sufficiency can be a higher tendency in rural areas. So motivational interviewing is particularly well suited for that. Also thinking about the sort of the aspects of motivational interviewing that respects autonomy and helps somebody sort of find their own path forward, helps us respect them, helps us speak their language, so to speak. So the implications here are that we might not know sort of what's culturally, what's the norm or what's more culturally acceptable or what's less culturally acceptable, depending on where we are. So this study that I referenced in the stigma talk is sort of showing us that the use of legal substances may be more accepted in rural areas like alcohol and tobacco. So, that's sort of us coming in with an idea with motivational interviewing where we're trying to speak somebody else's language rather than come in with our own language and our own agenda. So remembering that we can't focus on just a single path to recovery, motivational interviewing helps us avoid shaming and helps us come looking at somebody else's experience with curiosity rather than sort of us being overly directive. Motivational interviewing is not a way of tricking people into what we want them to do. It's not just a technique. It's not CBT. It's not easy to learn. It's not learned, like I mentioned, sort of like one time you hear of this idea and now you've got it. It's not our usual practice, and it's not going to solve everything. It's also not a Matt Foley motivational speaker talk. So let me summarize just a little bit what we've talked about and then open up for us to have some time for questions. So I can't emphasize enough my personal belief that we have to start with chapter 2 of this book. Basically, we have to start with the spirit of motivational interviewing. That has to come before everything else, before we start using, learning these skills and strategies. Motivational interviewing will help. I think that's supposed to be avoid. Sorry, it will help us avoid the extremes of hopelessness, that we can't do anything, or control that we can change anything. Any movement forward becomes a positive feeling for us, including any step in the stages of change. We've reviewed 3 of the quartets that come from motivational interviewing: the spirit of MI, the RULE acronym, and the 4 pillars. So, you can circle back to those or put a sticky note up for one of those four that sort of makes the most sense to you to be reminded of frequently. Motivational interviewing, we discussed it, is not a lecture and it's not an inspirational speech. Motivation for change comes from within somebody, and we are sort of a collaborator with them as they find that motivation. And then there's great skills that can be practiced and practiced and practiced again, developing our patterns of more productive listening, more productive communication. I have put in some references, and I think Nellie also created a really useful sort of resource sheet. And then Nellie, I'm going to turn the time back over to you to talk about the post-session survey and maybe launch the other poll.
That sounds good. Thank you, Peter. I'm going to launch the poll right now. It's very similar to the first poll that people filled out. It should be on your screen now. And we have an exciting opportunity for this session. As Peter mentioned earlier, the Motivational Interviewing in Healthcare book is a shorter version. I highly recommend it. I actually have a copy right here. And we'll be giving out 30 copies of it to the first people who want a copy and fill out our survey. There will be a survey distributed in a week from now, next Wednesday, via email. And it'll give you a chance to provide some feedback about this presentation and help us shape our future sessions. So we will be doing smaller workshops with some of the motivational interviewing skills that Peter has gone over today. And hopefully having a copy of this book will help you study up before those and kind of help you on your journey to incorporating motivational interviewing in your practice. And so we have a good amount of people filling out the poll, and this is a good time to have some questions. If you'd like to ask a question, feel free to raise your hand, and I will allow you to talk if you would like to contribute.
So we do have one question that has come in so far. We have some others, I think, as well. But so the first question here is, can you go back to the 2 questions to ask when seeing how ready someone is to change? They were something like, what's the best thing you can see about changing, and something about reasons for not changing. Thank you. Are we able to get Dr. Jackson back?
Yeah, so I'm back. So I didn't know if they wanted to just wanted me to just click on that slide, but I've put that slide back up. I don't know if there was a follow-up question to that.
Perhaps, yeah, perhaps this person just wanted to see, yeah, she says she just wanted to see them again. Also, people are asking about joining the next workshop, saying that they are interested in doing that. And you can join the next workshop for sure. You will get, as long as you're on our mailing list, you will get notice about the next ones coming up. And I will, I'll enter our mailing list again in a sec. Here's another question that has come in. It is, how do you work with someone who just won't talk to you like you're supposed to listen to them and they don't want to say anything at all?
So the question is, you're supposed to, we'll go to that 80-20 rule. So you're supposed to talk 20% of the time and have somebody talk 80% of the time. What do you do when somebody's not feeling their 80% of the time? I think one thing is we can get very comfortable with silence, not in an impolite way, but silence. There's nothing wrong with silence. Silence allows somebody to do a lot of thinking. If somebody specifically says, "I refuse to talk about this," respecting autonomy, there's a balance there, and you're not going to force somebody. You're not going to force or shame somebody into talking. I have found that silence is really powerful, and silence very often doesn't mean somebody's not willing. It means that they need a little bit more time to think. Particularly, we often have individuals that are facing co-occurring difficulties like anxiety, depression, or ADHD. So I get really comfortable with silence. If somebody says, I don't want the silence, just asking open questions. What's making it really difficult to talk? Is if they say, no, I refuse to talk. Is there anything that I could do in our session today that might make it more easy to talk? It sounds like it's really hard to talk about it, but you are here. What made you decide to come in, even though you don't want to do much talking? What made you decide to come in today? Just try to follow them and rolling with that resistance and sort of being with them where they're at. There are times where if somebody's becoming irritable or angry, I think our respecting their autonomy is allowing them to walk or be done. I think about this a lot on our child psychiatry unit where I work. Like the kids are never forced to have their daily check-in with the doctor. We try to find them at a time that might work better for them, but silence, asking the question a different way, just following the affect. It looks like this is really uncomfortable for you. Is there anything that I could change? Or am I observing? Do you think I'm observing that accurately, that this looks pretty uncomfortable for you? And in the end, we respect autonomy. As soon as it sort of turns towards irritability or anger, I think we respect autonomy by saying, I very much respect your decision to not talk about this right now, and that's fine. And that might be, sometimes the win is the win of the first visit is to get the second visit, or the win of the first conversation is just to get the second conversation. And if it needs to be a message like, I'll respect your autonomy if you really don't want to talk about this, then that could be it.
That's wonderful. Thank you, Dr. Jackson. Here's another question that's come in. Somebody is asking, how do I engage in MI when I'm only supposed to meet for 15 minutes?
That is a great question. Thank you so much for asking that, because I think that's on many people's minds. I believe strongly that if even in a 15-minute visit, if the person does more of the talking than we do, they're going to learn more. I've just come to really believe that and try to practice it. I need to check myself all the time on that. But I need to try hard to practice that. I just believe that people learn more about themselves when they do the talking than when we do the talking. So I think even in a short amount of time, the more we can elicit talk from them than from us is the right thing to do. I think that, you might not, so this is where we're sort of talking about the spirit and the skills. The spirit of MI can be with us in a 30-second conversation. The spirit of MI can be what they see in our face if we can truly accomplish it, if we can truly sort of accomplish the idea that every person that we're talking with, we can have unconditional positive regard for them. So practicing MI is it really is a mindset. So you can practice MI with somebody that you never even do speak about. I mean, I really believe this. I don't mean to get too like touchy-feely, but we can have a spirit of MI about us when we're riding on the elevator with somebody, just that person has worth, that we can have unconditional positive regard for that person. So I guess that's one of my answers to that, is that the spirit of it, the way that we approach people, what they're going to see in our faces can influence and impact and improve care, even when there's not a conversation, even when somebody sees us, just welcoming them to the clinic. I think the spirit of MI can be in our front desk staff. That's sort of my feeling about it. I think it can take more time to have some of these conversations. So if we're supposed to see people in 15 minutes and only 15 minutes, then we might need to see who else in our clinic has the time to really utilize some of these skills. So sometimes, the person who has a 15-minute appointment or the person who has a 45-minute appointment, the 45-minute person might be doing some of the actual skills like the change ruler questions or those types of things. But the spirit of it can be with us even in a 30-second conversation.
Thank you. Thank you. That's great. We have a couple more questions in about 3 minutes, so we'll see what we can do with these. Somebody is asking, what is the best way to redirect someone when they're feeling discouraged and wanting to resort to old ways in dealing with their pain and worried they will relapse? Redirect someone.
I think that we have to see if they can redirect themselves again. So it's this autonomy. Questions like, tell me the types of things that have been going on in your life that have made that feeling come back strongly. So we're sort of accepting the idea that they have feelings leading them towards relapse, and validating that, sort of recognizing that there's ambivalence all the way through, and then seeing if we can probe for them, like, tell me what that would be like for you. What are the pros and cons? As you've been thinking about that, tell me a little bit more, sort of how your mind is weighing that, and seeing, again, turning it back to them and seeing what they've already thought of. Because again, if they're coming in with that question, but they're already in your office too, right? So they have both of those arguments in them already. And so just sort of eliciting, tell me the way that you have been weighing this decision. And then as they give you their reasons for change versus their reasons for returning to use, you can reflect back their reasons for change, and you can ask more about them. Can you share a little bit more about that? Tell me more about why you feel reluctant, or tell me more about sort of what you see as the long-term downsides compared to the short-term upsides, and just trying to reflect back. So again, helping them answer the question, helping them find their motivation, recognizing that it's normal that they would be ambivalent, but that means they already have both arguments within them. And then even at that stage, helping them find their reasons and them explain to you, if you can, have them explain to you why they shouldn't return to use rather than you explaining to them.
Thank you. That's a wonderful answer. Really helpful. So we are going to have to finish up our wonderful presentation. Thank you so much, Dr. Jackson. You will hear from us. You will receive the recording and the slides next week, and you will also receive an opportunity to do a survey where you can win. If you're one of the first 30 people, you can win that book right there on the slide. Also, our next community round is on August 4th, and that is Telehealth for Substance Abuse. Here it is. Substance Use Disorders and Considerations for Rural Regions with Dr. Allison Lin. We're really excited for that one, and this has been wonderful. Dr. Jackson, you're getting lots of thank yous, great presentations, so people are appreciating very much. Thank you, everyone. We hope you have a wonderful day, and we'll see you next time.